The AHA Transformation Talk series of video discussions among healthcare thought leaders offers insights to help hospitals and health systems navigate healthcare's new disruptive environment and prepare for what's next. The goal of this series is to enable healthcare leaders inside and outside of the AHA to discuss innovative and transformative concepts to further educate their peers and healthcare community in the wake of the massive disruption caused by COVID-19, which has dramatically accelerated the imperative for action.
So far in our fight against opioids, what we've done really well is raise awareness of the issue. I think that now most Americans are aware that opioids are a top killer of people in our country. And we've done a lot of work to make treatment accessible to patients in places where they really need it via telehealth or emergency departments. But what we still have to do, I think, is a better job of understanding the great scope of this picture. There are so many more things that we need to do. With the introduction of fentanyl and other synthetic opioids that keep entering the country, the stakes are much higher. And some of the stuff that people thought that they were used to, or their tolerance level, or the dealer that they were using, between all of those new drugs coming in, and then also COVID-19, which changed the way that people access their drugs, we're dealing with a very different kind of danger than we were about a year ago. And so really we have to do a better job of increasing awareness, getting harm reduction tools into patients' hands, and also still fighting that stigma that we know surrounds drug addiction.
Our patients are hesitant to come and access care, being fearful of catching COVID. Some people that should be seeking treatment are hesitant to. The other thing, some that are in treatment are unable to do it in the method that they normally would have, for example, group meetings. And because of the concerns about social distancing and masking, there have been alternatives that are being tried. You know, one such method is using telehealth to have group meetings, for example. It's an opportunity to try substitution. For some people, it just doesn't work, and they need that, you know, personal one-on-one or group together, you know, connection and support. It bears out that we are seeing a decline in progress for some of our patients.
Well, we understand that what is not working is associated with the COVID-19 pandemic, and especially this isolation, this patient isolation. So overdose patients, for example, may not be resuscitated because they are simply alone. They have no one to care for them immediately or no one to take them to the ED.
For me as an emergency doctor, what this means is we have to do a lot more work in harm reduction. We have to educate people everywhere so that they know what's out there in their community and they're equipped with tools like naloxone or not using alone, just in case that happens to them so that we don't have people die who weren't trying to.
We need to make sure that we have the ability to test our patients, to have, you know, accurate readings of their situation. And then, you know, many times this is used as part of their therapy as they continue treatment.
So one of the things that has been working throughout this whole continued crisis, opioid crisis, is the fact that drug testing has provided the necessary information to the caregivers as to what the patient is addicted to, what they are taking, even in the event that the patient doesn't know exactly what they've been taking.
Between 1 in 4 and 1 in 5 patients that are admitted to a hospital have a behavioral health or substance use comorbidity. And yet, we don't always treat the whole patient. So we're sometimes focusing way too heavily on the presenting problem or diagnosis without really taking into account that there may be an underlying issue.
First, prevention. Make sure that your providers have really well drawn out guidelines for opioid prescribing. When do you actually need it? And then second, having an alternative to opioids or ALTO program in place. This allows providers to use non-opioid medicines and be way more familiar with them in the treatment of mild to moderate or acute on chronic pain.
I think our leaders really need to understand that, you know, most times this, or many times this substance use begins as legitimate treatment for pain. So, for example, post-operatively, we need to be responsible in the prescriptions that our patients go home with after surgery.
One of the key aspects of stewardship management has to do with comprehensive drug testing, and that leads to preventative competence and also for applying the appropriate continuum of care. It's understood what the patient is taking. It also is understood the prevalence of that drug use in the community, which can help to not only curtail drug use, but also educate the community on what is being abused.
Truly making treatment for opioid use disorder accessible to patients has two main parts for us. First, make that treatment accessible in the emergency department so that your providers are ready to start that medication for addiction treatment, that buprenorphine, right there when the patient shows up and is ready to start now. The second is being a bridge for them to the community. You want to have either a peer navigator, a substance use navigator, or even a social worker who's well connected and familiar with what your community has to offer. That gives the patient a warm handoff, not just a sheet full of resources, but somebody who's going to help them contact a human being at the resource that they need to make sure that they do get that ongoing support that they're going to need. For example, we had this patient come to my hospital once who got started on buprenorphine and was feeling great and was ready to go follow up in an addiction clinic afterwards, except for a couple of things. One is her insurance wouldn't pay for the medication at the pharmacy, and that clinic didn't take her insurance, and nobody seemed to answer the phone for the hour that she was trying to wait to talk to somebody during her lunch break at work. So we had a substance use navigator at our hospital, somebody who had met this patient when she was there in the ER and given her phone number. This patient called our substance use navigator, who was able to then address the problem with the pharmacy. It was actually just how the medicine was written, not an insurance problem. So we addressed that. And then that substance use navigator was also very familiar with the other follow-up options and was able to call around the people we knew at different clinics to find the better clinic to suit that patient's needs.
It's really important that hospital leaders are aware and plugged into what is happening in their community. That means conversations with the neighboring hospital, for example. If we're seeing this in our organization, I'm sure that the hospital 5 miles up the road is also experiencing the same thing. And we need to be tuned in and aware. This just really is about open communication between not only hospital leaders, but leaders in the community about what they're seeing.
To access AHA's tools and resources on opioid stewardship, please visit www.aha.org/